So we've talked about the descending pathways for the motor system, the peripheral part of the motor system, the anterior horn cells out, and but we've mentioned a couple times in those lectures about that there's other things that influence your motor output, and these are the control circuits. These things, they don't have direct connections. They're not directly connecting to anterior horn cells. They're not going and having any direct interaction with those anterior horn cells to drive your motor output, but they influence the pathways and tracks in different ways to modify, shape overall motor output and coordination. So that's what these guys are doing. They adjust the activity of those descending pathways. They help to regulate movement, but again, have no direct connection with lower motor neurons. Both the basal ganglia and the cerebellum, if they're going to go back up to the cortex to influence the next signal coming down those descending pathways, they're going to use the thalamus to go back up to the cortex. Remember, if you want to talk to the cortex, you typically have to go through the thalamus, whether you're a sensory signal coming up from the outside of the body or whether you're an internal structure that wants to go back and talk to the cortex. You use the thalamus. And they also, in addition to going up to the thalamus to go back up to the cortex, some of these projections go directly to some various brainstem nuclei to influence some of those medial activating pathways we've talked about, primarily for posture and gross movement and so forth. So let's talk about the basal ganglia first, sometimes also called the basal nuclei, right? Because remember, a ganglia is typically a group of cell bodies in your peripheral nervous system. This is the only place they talk about a ganglia in the central nervous system. So there's a push by people to call them the basal nuclei instead of the basal ganglia, but you're going to read it at 99% of the time. Structure and function. All right, I like simple. This is about the simplest layout I've seen of showing the basal ganglia and the different components of the basal ganglia, okay? So there are 5 individual components of the basal ganglia nuclei: the caudate nucleus, the putamen, the globus pallidus, subthalamic nucleus, and the substantia nigra. Those are the 5 components of the basal ganglia nuclei, individual discrete structures. You can take some of those nuclei and then further subdivide them into smaller groupings that also have names, okay, because of their association when they work together. If you just take this one here, the caudate and putamen, that is collectively referred to as the striatum, the caudate and putamen together. If you take the caudate, putamen, and globus pallidus, those are called the corpus striatum as a unit. If you take the putamen and globus pallidus together, they're just called the lenticular nucleus. Just be aware of those subcomponents, because some books and some of your readings will refer to the lenticular nucleus or the striatum, and we'll show you that relevance later on in here. So it just kind of orients you three-dimensionally in space here, how the basal ganglia are sitting in your brain. You have those structures, those 5 basal ganglia structures on both sides of your brain, and they're paired structures in your hemispheres. Okay, so here is looking down into your brain, and we see the thalamus on each side here that are really close together. There's that little space, the third ventricle between your thalamus, and they're sitting right there together. Then you move out a little more laterally, and you have the basal ganglia structures, at least part of the basal ganglia. You have we're looking at the outside here. This is the putamen. A little deeper in here, that little dotted line, a little deeper there is the globus pallidus, and then this kind of C-shaped structure here I'm circling here, that's the caudate. So caudate, C in the caudate, it's kind of a C-shaped structure, so that's the caudate. And you have that on both sides. If you see these little kind of like girders almost looking little connections here, and there's little holes there, what's interesting is your corona radiata. Remember the corona radiata, all those axons coming from your cortex? Corona radiata come down and they pass through some of those holes there, and then they actually then dive in here between the basal ganglia and the thalamus, and that's where your internal capsule is. kind of squeezed in there between the thalamus and the basal ganglia. And so that's kind of what those little holes there is, allows the corona radiata to come down through and pass in between, to go between the basal ganglia and the thalamus structures. This is the amygdala. The amygdala is a limbic system structure. It's not part, even though it's right at the tip of the caudate nucleus, it's not part of the basal ganglia. It's a limbic system structure. It has to do with fear, anger, and those kind of things for driving some of those responses. So now here's looking at just a left basal ganglia and thalamus structures deep inside a left hemisphere. And we're just taking away and cutting away the different layers from outside to inside. So here's this first dotted line I'm highlighting. If we cut that away, that's your putamen. Okay, so that's the putamen. And this right here is kind of this is the cut edge of the putamen right here that we popped off and cut away. Then the next structure deep to that would be the globus pallidus externus. The globus pallidus has an external component or external segment and an internal segment. So the next thing right here, which is this cut structure, that's the external part of the globus pallidus. And then we dig a little deeper and we get to the internal segment of the globus pallidus. And then the next thing in here is the thalamus. But running between those is those internal capsule fibers are all running in between that internal segment of the globus pallidus and that thalamus, is those deep white matter tracts running between. The substantia nigra is right in here. This is actually in your midbrain. It's a brainstem structure, so it's part of the basal ganglia circuitry, but it's sitting in the brainstem. But you can see it's relatively close to these other structures. We also have the subthalamic nucleus, which is sitting just below the hypothalamus. But they're all really tight in there, so that they're functionally and geographically right near each other. And so those are all the parts of your basal ganglia there. This is looking at, this is kind of like taking a lot of the structures away of your cerebral hemispheres. We're looking at the medial surface now of this is a right basal ganglia. We're looking at the medial surface of your right basal ganglia on this particular one. So, and this is showing you this area here. This is your globus pallidus, and it's divided. This is the internal segment, GPI, and this is the GPE, the external segment. And then this whole structure here, that is your caudate. In this case, the thalamus is gone. There's no thalamus in here, okay? And they're also showing you, so here is, this is your midbrain right here, right? Sitting right here, the cross section through your midbrain. Here's your red nucleus. And this is your crus cerebri. This is where those motor tracts run past. But then this dark substance here, this is your substantia nigra, and it extends up through your midbrain. So this is the substantia nigra, and this would extend up like this, a little bit higher up and through that whole little midbrain section, and that's your substantia nigra sitting there. And then this is your subthalamic nucleus right here, that is sitting just below your hypothalamus in your cerebrum. We'll show you that where it sits here in other cross sections. This is your anterior white commissure. Remember the anterior white commissure we saw? We looked at the medial surface of the cerebrum that connects the two temporal lobes, commissural fiber between the two temporal lobes, sitting right there. So here is now a horizontal section, and it's two horizontal sections, one that's through a certain level and one's a little deeper. Okay, so this, let's see if I use a better. This is A if you're facing it on your left-hand side. This cross section A is a cross section through this level right here of the basal ganglia. So this is showing you the basal ganglia structures and the thalamus right here, sitting here out there. And then little B right here is just a slightly, a centimeter deeper, lower down, horizontal, more a caudal cut more down here, just a little bit deeper, right through the center of everything. This one's a little higher, okay? So let's point out when you cross-section through these different areas here. So here is the caudate nucleus, and this is the head of the caudate right here that I'm highlighting. And then back here is the tail. And in a horizontal section like this, the head and the tail are always going to be right near where the lateral ventricles are. This opening right here, let me go ahead and change color. You know, this space or opening right here, and this space and opening back here, these are both parts of the lateral ventricles. And so you'll see that the head of the caudate right here is just a little posterior and a little lateral from this lateral ventricle here. And then the tail of the caudate is a little anterior and lateral to where this is, just right next to it, okay? And so what we're looking at here, so if we look at, let's go back to red, the head of the caudate, so we're in this section A right here, and so we're looking down at this little cut section right there, this little region right here, we're looking straight down on top of it, and that's what you see right here, is that cut part of that caudate, okay? And then back here, all we're seeing is this little tiny region right here, that little bit of section of tail back here. All of this up here is gone. That whole part's been taken off the top of the brain. So all we're seeing is just the little cut areas through the C-shaped structure of the head and the tail of the caudate. So that's what we're seeing there. Then this is your thalamus right here. That's that red structure right here. So we're looking, here's the cut edge, and we're looking straight down on the top of your thalamus there. So this is thalamus, and it's more medial. And then here is your globus pallidus. Well, let's start with putamen. So this most outside structure right here, this is the putamen. Then the next structure, it's a little more medial, is globus pallidus externus. And then there's another structure that's a little more medial, is globus pallidus internus, your GPI. And that's what we're looking down. You can't see it in here, but this is a cut right through here. This blue thing, they're looking from the outside, that blue thing is just a putamen. Then a little deeper to that, which you can't see on this side view, is there's a globus pallidus externus and internus in there, okay? And we see it on this side as well. So even a little deeper down, even a little deeper down cut right here, a little lower, will show us this. This is putamen, globus pallidus externus, and globus pallidus internus. This is head of the caudate. And there's a place where the head of the caudate and the putamen start to come together. In this region here, which is, you'll see right here where this is where that cross section is. Here's the putamen and here's the head of the caudate. They kind of join together there. And that's what we're looking down at, is this little joining structure right there. That region is referred to as the nucleus accumbens. You don't have to know that, but just you may see that referred to as the nucleus accumbens. It's just where those two structures sort of come together. And then remember, we have this is our internal capsule right here, and we have an anterior limb. This is our anterior limb, and then a posterior limb of the internal capsule. That's all I think you need to see there. Oh, this is kind of just for kicks, so you don't get confused. So you have, this is your internal capsule, right? This white matter. There's another kind of white matter structure just to the outside of the putamen called the external capsule. And there's a little bit of gray matter right in here. It's kind of part of your limbic system. It's called the claustrum. And then there's another little bit of white matter strip just outside the claustrum, between the claustrum and the cortex, and that's the extreme capsule. So he goes internal, external, and then oops, we got to think of something else for that next one, extreme capsule. Now here's a coronal section, okay, through the basal ganglia and thalamus as well. So kind of a mid-coronal section here. This would be your thalamus right here. Here's the third ventricle right between here. These are the lateral ventricles coming up this way. Here's that caudate nucleus right here. And in this section we're going to be, this is the body of the caudate. I should have showed you guys here. So there is multiple parts to your caudate nucleus. So there is this region right here would be the head of the caudate. This next section here, from about here to here, this is the body of the caudate. And then back here is the tail of the caudate. Okay. So in this cross section, would be kind of up right through the middle here. With that would be looking at, we're right through the body of the caudate here. So here's the thalamus, and then here's our putamen, globus pallidus, externus, and internus. So putamen, GPE, GPI. Those structures together are called the lenticular nucleus, those three structures together. And if you look here, this is the better appearance. This looks like kind of a bean, like a lentil bean, a lenticular looking structure. It looks like a lentil bean in a horizontal section, so it's called the lenticular nucleus, those three together. And the caudate structures and the putamen, those together are called the striatum. Okay, those grouping together is called the striatum. So now let's look at some cross sections through some horizontal, frontal plane cross sections through a brain, starting pretty far anterior. See where that cross section is right through the frontal lobes there, a little far forward. And the only thing we're seeing here is the big head of the caudate nucleus. Here's some lateral ventricles we're seeing. And so this cross section is right through here. So all we're seeing is this, we're looking straight on this way, and we're seeing this region right here, this pretty big. So you can see how big that head of that caudate looks when we're looking at it in this cross section right through that front part of the brain, that anterior part of the caudate. So we're right there through the head and kind of near the nucleus accumbens there, the big head of the caudate. The next cross section, we're a little farther back. And now we're seeing some thalamus here on each side. Actually, that's not thalamus. I'm sorry. We're not seeing any thalamus yet. This is actually part of the caudate. This is now working into the body of the caudate. We're kind of at a transition point. We're actually right about here. So we're seeing this pretty large section of the caudate, kind of in that transition between the head to the body right here. And we're also seeing this front part primarily right now, we're seeing mostly putamen here. That's mostly putamen because the globus pallidus, external and internal segments, just a little farther back. So we're mainly seeing, now these cross sections are never perfect. We're starting to see some globus pallidus maybe here and maybe a little bit there, but not much. This is mainly what we're seeing is just putamen because we're not quite far enough back to get through everything nicely. And we're seeing no thalamus. We're not even to the thalamus yet. Does that make sense? So yeah, the thalamus starts right here. The thalamus is back here, so we're not quite to the thalamus. So we're seeing, You know, this region of the putamen, maybe catching a little bit of the external segment of the globus pallidus, but no internal segment of the globus pallidus. Here's our internal capsule right here, coming down between there. Now we're farther back. Let me see here. And we are catching probably, we're probably right about here. This is the thalamus right here. Here's our third ventricle between the thalamus right here, and our lateral ventricles up here. So we're seeing right here is the body of the caudate. You'll notice the caudate nucleus, the C-shaped caudate nucleus runs right along kind of the inside edge of the lateral ventricles. The lateral ventricles have a C-shaped, and the caudate nucleus is running right next to the lateral ventricles. So you always see the caudate near the lateral ventricles. Here's the bottom tips of the lateral ventricles. These are the inferior horns of the lateral ventricles down here. There's a little space there, and there's a tail of the caudate here, and there's a tail of the caudate. It's really tiny down here because we're way down. Actually, probably. So let's move this slice back. We're actually probably right there, and so we're seeing this little tiny tip of the caudate right here and right here, where they run along just down near those inferior horns of the lateral ventricles, where they circle all the way down and around there. And so what we're seeing here from, this is putamen out here. We're seeing a little bit of globus pallidus externus maybe right there, and this is putamen. So what we're back to where the globus pallidus internal segments there, and the globus pallidus external is a little bit bigger, like this. So we're catching mainly putamen and globus pallidus externus, but we're a little bit behind the internal segment there. In order to get the best view of the internal and external segments in the thalamus, you actually need to make a cut through the brain. Oh, that's weird. That is a little more oblique in nature, so as opposed to a straight up and down cut, you kind of want to cut like this. A little bit of a oblique frontal cut, and that oblique frontal cut would kind of come down like this, like right through there, you know, is where you want to be, where you're going to get, you know, external and internal segments, and plus the caudate, plus the thalamus, and get everything in pretty good view. It's just a slightly oblique cut to get the best view on some of those. Here's your internal capsule. This is your midbrain right here that comes up into the brain right there. This is your red nucleus on each side right there. This is the substantia nigra. And then this region just above there, it's all packed in here. This is your subthalamic nucleus right here. Subthalamic nucleus. That's right where your midbrain starts. There's your red nucleus, substantia nigra, and then this region here would be hypothalamus right in here. Then this area here is your thalamus. See, it's clear as day. You can see those, they just pop out at you. Don't those structures just pop right out at you? But that's everything squeezed down into that little area there. So they're really close to each other, so you don't need very long axons for these guys to communicate with each other. Here's a cross section through an actual, horizontal section through an actual specimen here, just to show you. Head of the caudate, and this is your lateral ventricle, anterior horn of the lateral ventricles, posterior horns of the lateral ventricles back here. There's a little tiny tail right there. This one is hard even, this little tiny tail right there, but it's almost possible to see it. I just know it because that's where I know where it's supposed to be at. This cross section didn't get a very good internal segment, so there's putamen. This is globus pallidus externus. This one's a little bit better because these cuts they never get perfect, so slightly might be a little oblique. That's the globus pallidus externus. That's the putamen globus pallidus externus, and this is globus pallidus internus. That side, you can see the differentiation a little bit better on that side. Thalamus, thalamus. We're obviously in a horizontal section, we're not going to see any of those like subthalamic nucleus or substantia nigra. You only see those in a frontal section or coronal section. This is kind of cool. This is actually your optic radiations right here, which when we get to vision, these are the optic radiations. Your thalamus has a lateral geniculate nucleus, is where your vision comes into, and then it sends axons from there back through the optic radiations from the lateral geniculate nucleus of the thalamus. This is actually third ventricle right here. This little bridge right here across there, that's that little interthalamic adhesion. Remember, there's that little connecting stalk between the two thalami that most of us have. Not everybody has, but most of us have. That's the interthalamic adhesion right there. So normally, most cross sections, this would be totally open. You wouldn't see that interthalamic adhesion in the way there. So now let's talk about function of the basal ganglia. What does it do? These are some of the key things. It provides a trigger for the outflow of preparatory activity from the supplementary motor area. So remember, the supplementary motor area is a motor planning area. This is where we have some little mini programs stored for activities we do. And when you think of doing something, hey, I want to get up and walk, or I want to button my shirt, the supplementary motor area plays a role in that, but the basal ganglia allows that program to get released. So you think about it, that thought has to go through the basal ganglia, go back up to the cortex and say, okay, release the program and allow it to happen. So that's one of the things that helps trigger that outflow of preparatory activity from the supplementary motor area. It also cues the supplementary motor area to switch from one behavioral sequence to the next. So sit to stand is one behavioral sequence. Walk is a different behavioral sequence, or turn is a different behavioral sequence. And so to switch from sit to stand to walking to turning to sitting back down, each of those requires the basal ganglia to help you trigger that smooth transition or quick transition from one program to another, okay? Especially during more automatic type movements. The basal ganglia is really critical for motor learning in the automation of movement synergies. So if you're learning a new skill or task, your body will learn that there's certain strategies and synergies you use of muscle groups and patterns of movement. The basal ganglia will help to reinforce those so they're easier to call up again and trigger again without thinking about them, to become more automatic. So the basal ganglia helps to just regulate overall muscle tone and the force you would use when you send a signal to your lower motor neurons, the actual output of the force you'll actually use. So it's regulation of your tone and force. And it also helps to scale the movement intensity and amplitude. So how fast you move and the amplitude of movement, how large your movements are. It helps to keep those tuned in the right, give you the right amount of force, tone, amplitude, intensity you need for any given task. So that's what the basal ganglia does. So let's talk about the functional anatomy of the basal ganglia. We have the 5 components we've talked about: the caudate, putamen, globus pallidus, subthalamic nucleus. We've talked about the head, body, and tail of the caudate. We've talked about the external and internal segments of the globus pallidus. The substantia nigra is also divided into 2 distinct functional components. There's a pars compacta and the reticularis, okay, the substantia reticularis and the substantia compacta, or sometimes called substantia nigra pars compacta, okay? So if you just know compacta, you're going to be okay. Then we have what we call functional divisions, and these are, we've already shared these with you a little bit. We have the striatum, which is just the caudate and the putamen together. So the caudate, the head of the caudate and the putamen are the striatum. Sometimes you'll read them as neostriatum, is another term, is a neostriatum. Then we have the corpus striatum, which includes the caudate, putamen, and the globus pallidus, all 3 of those structures. Then we have just the pallidum, which is just the globus pallidus, sometimes referred to as the paleostriatum. And then the lenticular nucleus would be just the putamen and the globus pallidus together, is the lenticular nucleus. We saw how that looks a little bit lentil-like. So the basal ganglia, we're going to talk mainly about its role in motor function. But the basal ganglia plays a role in all of these. Motor function, eye movement, goal-directed behavior that we have, social behavior, and emotional behaviors. And there's 5 loops, essentially, that pass through this basal ganglia. So anytime I'm going to do a movement, especially goal-directed movement, I've got to send a signal, goes through the basal ganglia, back up to the cortex, then to release the motor program or the motor output that's going to happen. Or if I'm going to make a decision about, my life, and I want to make an appropriate decision about something that requires some kind of judgment or executive functioning, I'm going to think about it. It's going to have to go through the basal ganglia, then back up to the frontal lobe to then allow me to do or make that decision. Same thing with oculomotor movement, just moving your eyes voluntarily. There's a loop that you have to go through the basal ganglia that allows your eyes then to move. This is the non-reflexive. There's the brainstem-mediated reflexive eye movements, but this is goal-directed. This is where I'm choosing to look towards a certain direction. There's emotional limbic. How am I, my emotions and so forth have to go through this basal ganglia loop too. So there's these parallel loops that go through these structures that allow the outflow properly of both motor, oculomotor, goal-directed behavior, your emotions. So just understand that so this is why patients with Parkinson's disease, they have a lot of motor problems, but they can also have trouble with goal-directed behavior. They just rather not move. They'd rather not do things. And their spouse may be super frustrated with them, saying, how come you have no motivation? Come on, just get up and do it, or go do your exercise program. Well, they have Parkinson's disease, and the basal ganglia is affected, and their goal-directed behavior is affected. So there's no oomph. There's no signal in their basal ganglia telling them, go do this next thing, whether it be a motor task or some other goal-directed task. And their social behavior may be affected, where they get the masked faces and they don't seem as emotional anymore. And some of that just because their muscles in their face aren't moving as much, but some of it is actually just their affect is a little flatter because their basal ganglia plays a role in all this stuff. So, all right, let's get into the circuitry. Let's get into the little connections going on here. The basal ganglia motor circuit. This is the word that we describe this circuit is called the cortico. Starts in the cortex. Striato. It goes into the striatum, which is striatum is the caudate putamen. Those are the input nuclei. The cortex sends signals to the caudate and putamen, and then they get processed, and they go back to the thalamus, then back to the cortex. So that's why you say cortico, striato, thalamo, cortical. It's a loop. Does that make sense? That term that shows you it's a loop. Starts in the cortex, ends back in the cortex. Cortico, striato, thalamo, cortical. So I'm going to just show you I'm going to draw the loop here, kind of. Let's see, let's use a highlighter. So let's see how this went. I want to use a red, I think. So the signal starts in the cortex. I'm going to do something. I'm going to need my muscles to move. The signal is not sent directly to your lower motor neurons via the cortical spinal tract. First, it has to go through the basal ganglia loop. So you send signals to the caudate and the putamen. These are the input nuclei. They are processed within some of the other nuclei here. They go back to the thalamus. This is the thalamus. And then back up, actually I show it back up to the cortex, so it's basically a loop like this. And I should have oriented you to this. This is your thalamus right here. If you're looking at this head on, this would be, or if it's looking at you, this would be a right hemisphere. We're looking at a right hemisphere here. This is your little insula and your sylvian fissure there on the side. And this is the thalamus, and this is your globus pallidus and putamen. This is your head of your caudate right here. They don't show a tail on here, that's okay. This is your subthalamic nucleus down here, and then this is your substantia nigra right down here. So in general, the loop is like this. Starts in the cortex, goes through the basal ganglia structures, back to the thalamus, and back up. You know, so the loop is kind of like that. Now, not all of those signals go back up to the cortex. Some go down to brainstem structures from after they're being processed, but in general, that's the loop that occurs. Okay, so go back to pen. So caudate and putamen are the striatum, and these are the primary input nuclei of the basal ganglia. When those signals are first sent from the cortex, they're going to go into the caudate and putamen. And it makes sense. The caudate and putamen are out here in the periphery. They're the closest structures to the cortex, right? So it makes sense that they'll kind of go to those structures first. Then we have the globus pallidus externus right here, subthalamic nucleus right here, and the substantia nigra pars compacta right here. These are all considered processing nuclei. This is where kind of, once the input comes in, the connections between those structures determine how the output nuclei is going to act. And the output nuclei are going to be your globus pallidus internus right here. They're the output nuclei. This is going to be the final output back to the thalamus, here's the reticularis right here. The reticularis is going to have output either right to the brainstem or back up to the cortex, or to the thalamus. Sorry, back up to the thalamus. So those output nuclei, their final destination is a non-basal ganglia structure. They're either going back to the thalamus, or they're going directly to brainstem nuclei to influence those. They're not going to any other basal ganglia structures. So these guys are communicating with other basal ganglia structures. These guys are communicating with non-basal ganglia structures. The thalamus is not considered part of the basal ganglia, and same with your brainstem nuclei are not considered part of the basal ganglia. So input, caudate and putamen. Processing, GPE, subthalamic nucleus, and substantia nigra compacta. Output is the globus pallidus internus and the substantia nigra reticularis. The GPI is the primary one because it has the biggest, strongest connections with the thalamus. The thalamus is the relay between the basal ganglia back to the cortex. Okay? Whatever happened in the basal ganglia is going to affect the thalamus and its influence back over the cortex, positively or negatively. Okay? And there's two regions in the thalamus that process that information. There's the ventral anterior nucleus, the VA, and the ventral lateral nucleus. Okay? We've already talked about a VPL, the ventroposterolateral nucleus for the lower body, processing of sensory information, and the VPM for processing of sensory information in the face. The processing areas for the basal ganglia are going to be the ventral anterior and the ventral lateral part of the nucleus. The communication between these regions, between the axons that are joining these regions and these cells, these neurons, are using neurotransmitters. And we have inhibitory connections. If there's an inhibitory connections, it's going to be using GABA as its inhibitory neurotransmitter. If it's an excitatory type connection, it's going to be using glutamate. Those are our big ones, right? We know those are our primary excitatory inhibitory neurotransmitters in the CNS. We also, dopamine is critical in this circuitry. And dopamine in this circuitry can act as both excitatory or inhibitory depending on the type of receptor it falls on, okay? And we're going to talk about a couple pathways, these pathways through the basal ganglia. One of those is a direct pathway, and one's an indirect pathway. The direct pathway tends to be excitatory back up to the cortex. The indirect pathway tends to be inhibitory back to the cortex. dopamine, when it's being produced in the right amounts and being dumped into the putamen and caudate area where the signals come in, helps to make your direct pathway more active and your indirect pathway less active, or inhibits your indirect pathway. Okay? We also have acetylcholine that are in little interneurons in your putamen and caudate. Okay? And they have the exact opposite effect of dopamine. They tend to be inhibitory to the direct pathway and excitatory to the indirect pathway. So they balance each other out. So when you got appropriate amount of dopamine in your system, you have a certain level of excitement going back to the motor thalamus that allows you to have mostly normal movement when you need it appropriately. And you also have the opposing acetylcholine that does the opposite effect, and they kind of balance each other out. When you have the right amount of balance of acetylcholine and dopamine on the striatum, the caudate and putamen, that keeps the activity of the whole loop, both the direct and indirect loops, balanced so that you have the right amount of motor output. It's not turned all the way up, it's not turned all the way down, it's somewhere in the middle. Most of our systems, whether it's your heart, lungs, basal ganglia, nervous system, it's in the middle. And that's good to have it in the middle, because then you can turn it up from there or turn it down from there. Okay? So that's what we're having here, is this balance between excitatory and inhibitory influences. Okay? So let's get through this before we take a break. So this is the most simple kind of representation of this that I've found, of this direct and indirect pathways through the basal ganglia. Okay? So this is our cortico-striatal thalamo-cortical loop. This is the loop, or the connections between those structures within the basal ganglia. Okay? There is a direct pathway right here that looks pretty direct, and there's only the striatum, and then you have this little stopping point, then back to the thalamus. Then there's an indirect pathway. You got to go now from the striatum, and you have to stop at a couple other connections or stopping points along the way, or connections involved in this, and that's the indirect pathway. Remember, these are both functioning at the same time. This direct and indirect pathway, they're both functioning at the same time. Okay? So let's show you, and they balance each other out. One is inhibitory, one is excitatory. You don't want too much excitation, you don't want too much inhibition. You want somewhere in the middle. Okay? So let's show you the direct pathway. The solid arrows are excitatory connections. The dotted or dashed are inhibitory connections. The globus pallidus internus, we're going to primarily focus on the globus pallidus internus here. It's always inhibitory back to the thalamus right here. And the thalamus is always excitatory back to the cortex. So whatever you do between here and the globus pallidus internus will either tell the globus pallidus internus to be less inhibitory or more inhibitory to the motor thalamus, which then influences the overall excitation back to the cortex. So let's look at this from a pure math standpoint. And let's just do this. Sometimes this logic makes sense to people. You have here's a positive excitatory connection, here's a negative, and here's a positive. What do two negatives in a formula do to each other? Cancel each other out, right? If you inhibit an inhibitory something, it makes it positive. So these guys cancel each other out, and that means that's literally a positive there. So now if you look, positive, 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 the net result is that you increase activity back to the cortex via the direct pathway. That increases motor output when the signal is being generated at the appropriate level via the direct pathway through the basal ganglia. because it kind of makes, if this is a negative, if the globus pallidus internus has a tonic inhibitory effect over the thalamus, and if you now if your cortex excites or enhances, improves or facilitates the inhibitory ability of the striatum to inhibit the inhibitory influence of the thalamus, that means that you release the thalamus to be more excitatory back to the cortex. So it gets really, when you try to talk it through, it can get really messy. So that's why sometimes just saying, hey, it works. If you've got two negatives always make a positive. And that's in a math formula, and that's in any connection in the nervous system. They cancel each other out, two negatives. So we also have an indirect pathway that's working. It's got a positive. It's got a negative. It's got another negative. It's got a positive. It's got another negative and a positive. We got three positives, but now we got three negatives. Those two cancel out, but we're still left with a negative, okay? So overall, this is inhibitory because there's three negatives in this loop. So if that's all you know, that the ultimate output, the ultimate net result of those connections in the indirect pathway decreases the excitement or is more inhibitory back to the cortex, then you're good, okay? And that's just because you have extra connections that cancel each other out, but then you finally have another inhibitory connection. Now, so what you have here is now, when you have dopamine, you have some dopamine in your substantia nigra, correct? Well, there's cell bodies in there that have dopamine, and they project their axons up to the striatum. So substantia nigra, this is the pars compacta. This is where the pars compacta component is where your dopamine-producing cells are, okay? Those axons, those cell bodies are here, and they project to your striatum. And when they release dopamine, when they fall on D1 receptors in the striatum, they increase the activity of the direct pathway. And when they fall on the D2 receptors, they inhibit the indirect pathway. So when dopamine is at sufficient levels, being kind of squirted on at a constant level onto your striatum, it makes the direct pathway a little more active. The direct pathway is excitatory, and it keeps the indirect pathway down-regulated a little bit, so it's a little less inhibitory over the thalamus. And so dopamine at the right levels in your basal ganglia circuitry increases motor output. That's why when you don't have enough dopamine, you don't move as much. That's why people with Parkinson's disease have trouble moving, because now they don't have enough stimulation of their direct pathway and enough inhibition of their indirect pathway. To counterbalance, remember, acetylcholine is also in here, has the exact opposite effect. Acetylcholine inhibits at the striatum. So you have acetylcholine right here in interneurons that are actually located in the striatum, and it's inhibitory to the direct pathway and excitatory to the indirect pathway. So they kind of balance each other out a little bit. It's all about balance here. So when you have the right amount of dopamine and the right amount of acetylcholine, you have this delicate balance between just enough motor output, not too much, not too little. They're balancing each other out in different ways. And then this will make more sense when you understand when you give somebody medication that's to replace dopamine or to break down acetylcholine, acetylcholinesterases that break down acetylcholine that you give to Parkinson's patients. That will influence the ultimate activity of both these direct and indirect pathways to try to maximize or normalize movement. Let's get through these two pictures here. This is a little more anatomically correct here. And this is actually, there's a resource guide that I put on in your course materials for this basal ganglia. There's a really incredible paper on the basal ganglia that's very clinically and very readable, and that's where I pulled these images from. I would say if you just read through that, they do a better job than I could do lecturing. It's just reading through that and trying to understand this. So let's look at this. This would be, if you're facing it, well, this is a right cortex and a left cortex over here. So they just don't show anything on the. So this is the midline of your cerebral cortex here. This is the cortical thalamocortical loop right here. Is what we're talking about. This is the loop here, and this is the direct loop that they're showing here. And they're showing the connections here between the cortex. And this is the striatum, which is your putamen and caudate together. This is putamen and caudate together right here. And that's excitatory. And then you have this direct loop where you just go boom, and you go right to the internal segment of the globus pallidus. And that's an inhibitory connection to an inhibitory connection between the globus pallidus internus and the motor part of the thalamus, which is in the ventral anterior and ventral lateral part of the thalamus. Then that goes back and is excitatory to the motor cortex, then will influence signals coming down through the lateral cortical spinal tract. Okay, so that's the direct loop. Then the indirect, the cortex communicates with the striatum, but then it stops at the external segment via an inhibitory connection, and then the external segment goes into the subthalamic nucleus down here via an inhibitory connection, and then the subthalamic nucleus goes back up to the globus pallidus internus via excitatory connection, and then the globus pallidus internus finally then is influencing the motor thalamus back to the cortex. And so, but because of these connections, because of the extra negative inhibitory connection in this circuit, it decreases activity of the motor cortex. This increases activity of the motor cortex. This one decreases activity back to the motor cortex. And they counterbalance each other. Told you to buckle up. And now here they all both together, okay? So remember, these are all happening at the same time. So here is the direct pathway here, and then here is the indirect pathway here, okay? And they're both happening at the same time. And now what we've done is we've added in let's go with green maybe. Here's the substantia nigra, and here's those cell bodies that produce dopamine. Then here's the dopamine being dumped into the striatum, into both the caudate and putamen. When dopamine is dumped into that, it has an excitatory effect on the direct loop right here, because when it binds to D1 receptors in the direct pathway, it makes the direct pathway ramp up its activity, and it has an inhibitory influence over the indirect pathway when it binds to D2 receptors in the inhibitory pathway. So when dopamine is in there, it's just saying that all it's doing is making that the direct loop has more of a role over the motor thalamus and the cortex than the indirect loop, which is a net increase in motor activity. Then remember, now we've taken dopamine out of the picture here, and now we're looking at, you also have these little interneurons inside the striatum for acetylcholine that have the exact opposite effect. They have a negative impact over the direct and a positive impact over the indirect loop. So dopamine and acetylcholine have they're counteractive to each other. They have the exact same opposite effects, but when you have the right balance, you have enough dopamine and enough, not too much, not too little acetylcholine, you have this balance between stimulation via the direct loop, inhibition of the indirect loop, and counterbalancing by the acetylcholine, and it's the right amount of movement that you get, okay? So then we get into why you have either too little movement with Parkinson's disease or too much movement with Huntington's disease. you lose that balance. That's all about you losing that balance on those neurons that maintain that balance, and that's what we'll get into after you get back from your needed break, well-deserved break in a few minutes here. All right. So now let's talk about disorders of the basal ganglia. Now that we know the normal we got the normal function of the basal ganglia down like that, we're going to talk about how we can screw it up and what happens to the basal ganglia. So we can divide basal ganglia disorders into two main categories. They're hypokinetic disorders, that means too little movement is happening, or hyperkinetic disorders, which is too much movement happening. So, you know, hypokinetic disorders, the most common is going to be your idiopathic Parkinson's disease. We don't know what causes it. Usually comes on in your late 50s, you know, or so, and can lead to too little movement. Then there's also secondary types of Parkinsonism. So these are not idiopathic Parkinson's disease. We know what causes them, but they lead to Parkinson-like symptoms because they impact the basal ganglia, similar to Parkinson's disease. So we can have toxic, where you have like carbon monoxide poisoning, can actually selectively damage basal ganglia neurons. Infectious, you can have infections that damage the basal ganglia. Traumatic, there's Parkinson pugilistica. Pugilism is punching, and so like guys, they get their head beat around a lot. There's a lot of torquing that happens between the midbrain and the cerebrum, and you can shear the axons, the striatonigral, which is striatonigral, striatum and substantia nigra. That's your dopamine-producing cells. You can shear those, and like Muhammad Ali. You know, we don't know if he had idiopathic or pugilistic. I mean, it could be pugilistica. Obviously, he was a boxer for all those years. Can shear those axons so you don't get enough dopamine getting back up to the direct and indirect loops. Then there's what's called Parkinson's plus syndromes. These have the cardinal signs of Parkinson's disease, but plus some other thing going on, like progressive supranuclear palsy that involves some of the visual nuclei in the brainstem. So they usually involve some other brainstem structures having degeneration. So progressive supranuclear palsy, the people, their eyes are always, they have a hard time looking down. Their eyes are diverted up. They also have a lot of swallowing problems, and they end up usually dying because they have aspiration pneumonia or something like that. There's multi-systems atrophy. Multi-systems means the basal ganglia can be affected, but so can other nuclei in the brainstem structures that can cause autonomic nervous system dysfunction, those kind of things. Also dementia. There's Lewy body disease, which also has Parkinson's-like things, but with also protein deposits in your cerebrum that cause dementia as well. So you have this Parkinsonism plus this Lewy body disease. Some people, even with Alzheimer's and dementias, also start to get some Parkinson-like. They have a dementia, senile gait, where they walk with a very, you know, kind of shuffling gait because they lose some basal ganglia neurons too, in addition to the cerebral cortex. Then we have hyperkinetic disorders. Huntington's disease is very rare. It's a hereditary disease, but causes the stereotypical choreic extra movements, the dance-like movements of athetosis and chorea, kind of superimposed on each other. There's also a rare kind of forms of things called dystonias, where people have these postures where they're like cramping postures, but their arms or legs might be in these kind of weird, sustained but writhing type, almost like an athetosis, but they're stronger than that, and they hold these postures. Those are dystonias. They're very painful and they're very disturbing, and they're hard to treat. Certain types of cerebral palsy, the basal ganglia can be affected and cause too much movement in cerebral palsy. Hemiballismus, that's the one where the subthalamic nucleus, which is part of the indirect loop. When you damage the indirect loop, the direct loop is overactive because you're not being balanced by the indirect loop. If you damage the indirect loop, now you don't have that negative influence of the indirect loop, whatever it does have influence, and now you got too much movement happening. That's why they're doing their little flinging of the arm or leg. So for idiopathic Parkinson's disease, there's 4 cardinal signs. There's typically rigidity. They are stiff. They're rigid. Their trunk and limbs can get very rigid, hard to move. They have akinesia and bradykinesia. Akinesia is initiation of movement. So when you tell them to stand up out of a chair, there's a delay before they even start to move. Bradykinesia is the actual slowness of movements, but when they actually do move, it's still slow. So there's the akinesia is the lack of movement, the initial lack of movement or delay in starting the movement. Then the akinesia is the slow movement once it started. Okay. Tremor, a lot of them have a resting tremor. Okay. And then, although they're not sure, it's something to do with some balance in that acetylcholine dopamine thing, but why that rest they have extra movement. It's really a hypokinetic disorder, but at rest they have a tremor that's got a little extra movement, but overall it's a hypokinetic disorder. And then postural instability. They don't have good postural control and balance, because part of that's because they're kind of rigid, and they also move slow. So if they get pushed over, they're stiff, they can't make nice subtle adaptations, and they can't take a large enough, quick enough step, amplitude step to catch themselves or make those postural adjustments in a fine, quick, smooth way. Okay, so it leads to postural instability. And there's people that are more predominant tremor, where they have a lot of tremor at rest, but when they're walking, they're moving, you hardly notice that they have Parkinson's. They don't have a lot of bradykinesia or akinesia. And then there's a gait and balance, postural instability predominant one, where they have the stiffness, they have the shuffling gait, they have the freezing, where they get stuck between going from one thing to another. Remember the basal ganglia is important for shifting from one program to another. So like standing up, now walk. And they get frozen because they can't shift from the sitting to stand program to the walk program. Or they even come up to a doorway, and just the visual kind of change and seeing a doorway to have to pass through or walk over a line, like into an elevator or anything, it requires you altering your walking program just a little bit to step over that line or to miss that line, or to even walk through the door. You makes you think about it for a second, and it turns off the automatic program, and you have to tell yourself to keep walking, and they have trouble doing that. So they get that freezing of gait anytime there's a transition, a turn, going through a door, some kind of thing that requires them to have to make a conscious kind of decision about it. You want the tremor, if you're going to get Parkinson's, you want the tremor predominant. Even though it looks horrible when you're sitting there, it affects your daily life less. And the tremor predominant responds really well to deep brain stimulation and almost eliminates, you've seen it on TV maybe, where there's somebody just sitting there and then they turn on their simulator and it's gone. The tremor's gone and they look fine. The gait and postural instability people, they don't do as well with deep brain stimulation. Doesn't seem to help them nearly as much. It helps them some. If they have a mild tremor, it might help that. People with tremor predominant, though, don't respond quite as well to dopamine replacement to diminish the tremor. People with the gait and postural instability, you give them dopamine initially, they have a pretty nice response, but only lasts for 10 to 12 years, and then they start to have too many side effects, and your body loses the ability to adapt or develop some tolerance to the drugs. So the pathophysiology behind this is Parkinson's is a loss of dopaminergic. They produce dopamine in the substantia nigra. This leads to a decreased activity of the direct loop and an increased activity of the indirect loop, because you lose excitation of the direct and you lose inhibition of the indirect, right? Because remember, dopamine, when it's going into those two loops, it makes the direct loop more active, which excites the motor cortex, and keeps the indirect loop less active, so it can't inhibit. So the net result is excitation. So when you lose dopamine, you lose excitation. And then you got acetylcholine in the background also leading to a net inhibition. Okay? So you get a net decrease in output from the motor thalamus and a net increase in activity of the reticulo and vestibulospinal tracts. That causes the rigidity. So the thing we haven't mentioned yet is, so we've only talked about the basal ganglia going back to the cortex. Well, there's also, basal ganglia has outputs directly to a couple brainstem nuclei that influence your medial activating system. Okay? So the basal ganglia goes into the cortex to influence the voluntary motor output, but it also has some influence over your background postural and girdle muscles that set the stage for that voluntary movement. And that's primarily via the pedunculopontine nucleus, and we'll show you that in a second here. There's a scale used to describe the level of severity of patients with Parkinson's disease, called the Modified Hone and Yahr scale. It's a 1 to 5 scale. At a 1, they just have unilateral. Most of the time it starts on one side more than another. Even though both substantia nigra eventually get impacted, one starts a little bit before the other. And actually, you have to have an 80% loss of your dopamine-producing cells to actually start to first see symptoms. So you can have this, by the time you get Parkinson's in your 50s, the loss probably started happening in your 20s. And it's not till you reach that 80% threshold, because you actually have some redundancy. You have enough dopamine-producing cells to get by for a while, but once you reach that critical threshold, you start to see symptoms. And they usually start on one side a little bit before they start on the other. So you might, 6 months, a year, you'll notice, hey, my right side isn't moving so well, or it's got a little tremor, and then it goes to your left side, and then both sides get involved. 1.5 is unilateral and axial, so they've got one arm or leg plus some trunk stiffness. 2, they have bilateral involvement, so now you're seeing both limbs involved, but they don't have major problems with balance yet at this point. 2.5, they have mild bilateral disease, and you do a pull test, you pull them backwards, they're still able to recover. They're not falling over when you do the pull test, but it's a little more bilateral involvement. It's a little worse than at a 2. Okay. 3 is a mild to moderate bilateral disease, some postural instability. You're noticing that their balance isn't quite as good. They might not recover from that pull test as easily, but they're still physically independent. They're still walking around, still in their house and maybe in the community, but maybe they're not even maybe using walkers or anything at this point. 4 is severe disability, still able to walk or stand unassisted, but they might be using an assisted device. They're not somebody's not to physically lift them. Then 5 is they're wheelchair bound or bedridden unless aided. It's just a very crude scale, but you'll see it in literature when you're reading a study on Parkinson's disease. It'll say the demographics. These were people in Hone. Most of the studies are Hone and Yahr 2 or less. So that means they're using people pretty mildly impaired. When you're looking at those studies. This is cross sections through a midbrain. Here's our red nucleus on each side. This is the substantia nigra. This is a more normal-looking substantia nigra that is darkly stained. And then here's somebody with Parkinson's disease. There's no way to confirm Parkinson's disease. There's no test for it. There's no blood test. There's no MRI that actually shows that. You actually have to determine it on autopsy. But it's really just the diagnosis is based on the constellation of symptoms, and you can get pretty darn close. I've had patients, though, who initially have that diagnosis of idiopathic Parkinson's disease. We start treating them, and this is where you guys come in and see this stuff a lot faster. So, in fact, I remember there was actually a professor here at UD a number of years ago that I was treating when I was working at Kettering Hospital full time, and he came with idiopathic Parkinson's disease diagnosis. I was working with him, and he wasn't scheduled to go back to see his neurologist for like 6 months. And I was working with him over a month and a half, and I noticed that he was having a lot more additional symptoms and faster progress than I would expect with idiopathic Parkinson's disease. He started having more autonomic nervous system dysfunction. He was passing out on us, and he was having more cognitive dysfunction than I would expect that quickly. And so he ended up with multi-systems atrophy versus Parkinson's. We also noticed that he wasn't responding to the dopamine replacement. Idiopathic Parkinson's disease responds really pretty well to dopamine replacement initially. Most of the other Parkinson's plus syndromes, like multiple systems atrophy, Shy-Drager syndrome, some of those other ones like that, don't respond as well to the dopamine because there's other nuclei being damaged in addition to the basal ganglia, and their symptoms don't respond as effectively. So between not responding to the medication and having a rapid decline plus other systems, boom, we got him back into the doctor. Not that we were able to help him necessarily anymore because there isn't a lot of other resources or meds that can help with that, but it was just like, hey, this is happening more quickly. We need to get more resources going. We need to get him help in the home. We need to get assistive devices. We need to help his wife out. We need to get them contact. It was more of the support systems we need to get in place now pretty quickly. And he had a really quick decline and passed away within a year and a half. So that was tough. All I want you to appreciate from this picture is so far we've focused on, here's the basal ganglia. And here is what we've talked about so far. This is the motor thalamus to the motor cortex, back to the cortical spinal tracts, to the lower motor neurons, to the voluntary muscles. This is how the basal ganglia influences the output of the muscles. These black are inhibitory, the red are excitatory connections. I just want you to appreciate here that when the basal ganglia is appropriately tuned between the combination of dopamine and acetylcholine, the basal ganglia, the output nuclei, the globus pallidus internus, are always tonically inhibitory. It's just, are they extra inhibitory or less inhibitory to this next structure they're going to communicate with? When everything's balanced, there's a certain level of inhibition, not too much, not too little, to both the motor thalamus, and then there's the pedunculopontine nucleus in the brainstem. Okay? The influence over the motor thalamus affects the voluntary muscles, how well we move our voluntary muscles. The influence over the pedunculopontine nucleus is how well our postural system is set to superimpose our voluntary control over. Okay? And so you'll notice, though, that the pedunculopontine nucleus has generally an inhibitory influence over the reticulo and vestibulospinal tracts, which then affect lower motor neurons of the postural and girdle muscles. So appreciate, though, here just the size of these arrows and the balance between them. Just appreciate that. When you have Parkinson's disease, the basal ganglia now is more inhibitory to the next structure, to both to the motor thalamus, it's more inhibitory, and to this pedunculopontine nucleus, because you're losing the excitatory influence of the direct loop and you're getting a little extra action of the indirect loop. So overall, it's more inhibitory now. And because of that inhibition, you see you're inhibiting right from the get-go, so all of these arrows are a little smaller and narrower. There's less excitation to voluntary muscles. But because the pedunculopontine nucleus is inhibitory here, you're increasing the effect of you're decreasing the effect of the pedunculopontine nucleus over the reticulospinal tract, so the reticulo and vestibulospinal tracts become overactive. And now you have increased activity of the posture and girdle muscles. That's where the rigidity comes from. So you lose facilitation over voluntary muscles, but your postural and girdle muscles, they ramp up. The tone on those goes up, and you get a lot of co-contraction around your joints and so stiffness, so they get really stiff, so that even makes it harder to move voluntarily, and that's where the rigidity of the trunk and the limbs comes from, is the overactivity of postural and girdle muscles. I mentioned these Parkinsonisms. Those are these secondary and different types of Parkinson's disease. There's similar signs. There's toxic Parkinson's. I said carbon monoxide, manganese poisoning. There's certain drugs. MPTP will selectively kill off Parkinson's patients. I'm not Parkinson's, dopamine cells. We don't want to kill them off. There was a movie about this. There was a drug the drug addicts were taking that was what's the name of the movie with Robin Williams? It's an old movie. But there was some drug addicts, and one of the variations of one of the drugs they were taking ended up with a molecule MPTP in it, and what it was doing was killing off their dopaminergic cells, and so these drug addicts were ending with Parkinson's disease, and this guy finally figured it out, that this molecule MTPT, which was in their drug, or whatever heroin or something got in there, was causing this. But then now they had a model they could use this. So this is what they use when they give like mice and primates and stuff. They give them this to make them have Parkinson's disease, so they can do research on how to help people with Parkinson's disease. They can selectively kill the dopaminergic producing cells by giving them this MPTP. There's infectious, there's traumatic, multi-systems atrophy, these are Parkinsonisms. You can have cerebellar degeneration with these, as well as autonomic dysfunction, Shy-Drager syndrome, PSP. These are all different types of multi-systems atrophies. Don't have to we'll get into these when we get into Parkinson's in your clinical neuro in the fall. We'll have a case study, and you'll have to know all these in much more detail. Okay. So Parkinson's disease, holy crap. Here is loss of dopamine cells. So we lose these dopamine cells that on the direct pathway are normally excitatory to the direct pathway, right? So all we have left here is acetylcholine that's inhibitory to that direct pathway. So the net effect is that we get there's less activity in the direct pathway. There's less excitation back to the cortex. Then on the flip side of that, remember dopamine here, it's gone. It normally inhibits the indirect pathway, but now all we have is acetylcholine left here exciting the indirect pathway. So the indirect pathway becomes more active, which is inhibitory back to the cortex. So you get a net effect of Parkinson's disease is get direct pathway activity to go down, indirect pathway activity to go up, which is the net effect is less activity back to the cortex. Then we have hyperkinetic disorders, things like Huntington's disease, which we've talked about these different movements in chorea, athetosis, hemiballismus, and dystonias are all forms of hyperkinetic disorders that involve some dysfunction of the basal ganglia that creates too much movement. So in Huntington's disease, what happens is you get degeneration of acetylcholine interneurons in the striatum. So what happens then is if you're losing acetylcholine cells, so these normally help balance the dopamine effects of dopamine. And so you lose, normally acetylcholine inhibits the direct pathway. So now I just lost the inhibitory effect of the direct pathway, and it excites the indirect pathway. So I lost that. So now we have only dopamine influencing the direct and indirect pathways, which dopamine in the right amounts is going to be excitatory. But now, so it's too excitatory now. You only have the dopamine influence and no more acetylcholine influence that normally would help balance out the dopamine influence. And so now they have too much movement because it's too excitatory. The direct loop is giving too much of an influence over the output of the basal ganglia, and the indirect loop is not having enough influence because of that loss of acetylcholine cells. But remember, the dopamine cells in Huntington's disease are perfectly fine. They're still dumping all their dopamine in. They're unbalanced by acetylcholine now. This is a cross-section through a brain of somebody with Huntington's disease. First of all, just appreciate how much atrophy. See all the spaces between the gyri and so forth. There's just a loss of neurons in general. They get a lot of dementia because they lose neurons throughout the brain. But this is the caudate here. It's a little bit bigger in this brain here. This caudate is a little smaller. It's atrophied in here. And the putamen here gets a little more atrophied. This putamen is really pretty big here on this side, a little bigger putamen here. So you get atrophy of the caudate putamen because you're losing acetylcholine cells inside of there. And the volume of them gets a little smaller. Hemiballismus we mentioned. Remember, this diagram is showing both direct and indirect pathways that are balancing each other out. But in hemiballismus, you lose cells right here in the subthalamic nucleus. So you're losing these cells in the indirect pathway. So now the direct pathway has too much influence, and the indirect pathway can't balance it out. So that's why you get too much movement of a limb or whatever on the opposite side of wherever this is occurring, whatever subthalamic nucleus is occurring in. Woo! All right, we got a half hour to get to the cerebellum. Got that basal ganglia down? Structure and function of the cerebellum. Another control circuit. More for coordination, okay? More for shaping ongoing function of the body, but also for motor learning. It's very important for motor learning. What happens in the cerebellum? You get massive sensory input in the cerebellum. Cerebellum has 10 times the neurons of your entire brain, your cerebrum. Cerebellum is part of your brain, but it's got 10 times the number of neurons than you do have in your cerebrum. So there's massive information coming in. It requires a lot of neurons to process that information. It compares the actual motor output to what you intended to do. When you send a signal down to tell your muscles what to do, there's an intention you have. You have an intended movement or outcome you're expecting. When you start to actually do the movement, that outcome may change. That cup you went to pick up is heavier than you thought. That door you went to pull on is lighter or heavier than you thought. And so as that happens, you might have to, the next signal you send down, you might have to adjust the next signal. The cerebellum helps to do that very quickly and smoothly. So you can adjust your motor output to existing ongoing conditions that are always changing, right? Most of the time. Not always, but most of the time. It modifies motor acts initiated by other parts of the CNS. It's essential for good coordination. It's especially important for equilibrium during rapid movements, when you take rapid movements and maintain your equilibrium and balancing your agonists and antagonists and keeping everything, you know, especially when you don't have time for conscious changes to your equilibrium. It's especially also important for damping of rapid pendular movements. The cerebellum is most active when you're doing things where you do rapid pendular movements of your limbs, where your limbs have to accelerate and decelerate, but do that repeatedly and smoothly to dampen those movements so it just doesn't look herky-jerky. And when, especially like doing this, that's why when we test coordination, we do this to somebody and have to do it rapidly. That's a rapid pendular type movement. It's going back and forth, back and forth. The cerebellum is really important for getting to the target, slowing your limb down, and then reversing it in a very smooth way by adjusting the signal to your limbs. And it's very important for motor learning. If your cerebellum's damaged, it's really hard for your system to learn new tasks because it's like your air detection system. It detects air in the system. And if you can't detect air, how do you make corrections? And how do you ever learn from those mistakes if your cerebellum's damaged? So patients with cerebellar damage, oftentimes my goals are lower or my goal setting is longer term. There's cerebellum's not totally gone most of the time. There's still there's ability for improvement, but it may be harder, or the threshold or the ultimate place we can get them may be a little bit lower than somebody who doesn't have problems with the cerebellum. So anatomy of the cerebellum. Let's talk about the anatomy. There's the gray matter, just like our cerebrum has gray matter. The cerebellum has gray matter. There's 3 layers of that gray matter. There's the molecular, the Purkinje, and the granular layers. The outer and inner layers contain interneurons. The granule, Golgi, stellate, and basket cells, those are all interneurons that are in the outer and inner layers. The middle layer is the Purkinje layer, okay? The granule cell axons divide into these parallel fibers. We'll show you a picture of this. The Golgi, stellate, and basket cells are all inhibitory and cause lateral inhibition within the cortex. So most of the interneurons in your cerebellum are inhibitory. And the reason why most of them are inhibitory is because you don't want signals to spread in your cerebellum. You are sending discrete signals from your body into your cerebellum, and you want them to go to a very specific location, and then you want the signal that's going to adjust the next motor output coming out of that same little region. You don't want kind of like areas of the cerebellum interfering with other areas of the cerebellum, because the cerebellum is so important for error detection and modifying movement and discrete movements that you have to package the information in these select little packages that are very specific to the movement they're trying to create. So you don't want a lot of crosstalk between, you want the signal going into the cerebellum to go to that little part of the cerebellum, because that signal is going to go back out and influence this little specific movement. You don't want a lot of crosstalk. So there's a lot of inhibition in the cerebellum to prevent crosstalk. Okay? The middle layer contains Purkinje cells. These are the output cells of the cerebellum. These are how information gets out of the cerebellum, is via purely the Purkinje cells, which are in the middle layer of that cortex. You have afferents. Information has to get into the cerebellum somehow, right, to be processed. That tells about the condition of your body and what's happening. You have what are collectively called the Mossi fibers. The Mossi fibers are all the fibers and axons. These are just axons coming from your spinal cerebellar tracts. Remember, we mentioned those 4 spinal cerebellar tracts. Also the reticular formation from your brainstem. The vestibular system, your vestibular nuclei, Mossi fibers come from those, from our inner ears. And then the pontine nuclei. Okay, and the pontine nuclei will show you what the role they play. Then we have climbing fibers. Climbing fibers come from the inferior olivary nucleus in the medulla. The inferior olivary nucleus is almost like a little mini cerebellum. down in your medulla. Inferior olivary nucleus receives input from, it gets a copy of your motor message, plus it gets some information from spinocerebellar tracts. It's kind of like a backup system, provides some redundancy, but the climbing fibers come from the inferior olivary nucleus. Those how the two different types of major afferent fibers get up into the cerebellum. So this is just showing you a cross-section through the cerebellar cortex. This is the three layers, okay? Molecular layer on the outside, Purkinje layer, which is just where the cell bodies of the Purkinje cells lie, and then the granule layer down here. So we have our granule cells here. You'll see the granule cells. They project up into this molecular layer. Then they have these fibers that run parallel to each other all across the cortex of the cerebellum. And these are inhibitory, these parallel fibers. So this divides these regions into very discrete little small segments, so you can package information into these very small discrete segments for this really intricate processing that's going on. So you just don't have, like you say, crosstalk and information spreading. These are stellate cells out here. These are all inhibitory interneurons. This is some of the basic circuitry within a functional unit of the cerebellum. Here is fibers coming up, okay? This is the climbing fiber from the inferior olivary nucleus, and these are mossy fibers coming up, okay? These are coming in to the cerebellum. Remember, through that, a lot of them come in through the inferior cerebellar peduncle because they're coming from your body. There's a few of them that go up to the superior cerebellar peduncle, but we don't worry about that. They come in, they branch, and they actually give a little excitatory impulse back to the Purkinje cell here. On their way up then to the granule cells, which also, and then also here, this mossy fiber is excitatory to the Purkinje cell. The Purkinje cells are always inhibitory. Purkinje cells are always providing, Purkinje cells are always giving a baseline inhibitory tonic influence over their output. So here's theoretically what they think somewhat happens with some of the control mechanisms in the cerebellum. There's what's called the deep excitatory loop and then the cortical inhibitory loop. So what happens is, this is especially important for pendular movements. If I'm rapidly accelerating a limb, I'm going to do something really fast in pendulatory movement. As that signal comes in to my cerebellum, my muscle joint receptors and my muscle spindles are rapidly being stretched and so forth. It recognizes that. It goes to the deep cerebellar nuclei. There's some nuclei in the cerebellum, and excites them and increases the activity back to that muscle initially. Okay? A millisecond later, these fibers going up stimulate the Purkinje cell, which is inhibitory to that. So you get an initial excitatory boost to the deep cerebellar nuclei to go back to the muscles. And then a brief moment later, a few milliseconds later, you get this inhibitory influence to slow it back down, because it knows it's going to have to dampen that movement briefly right afterwards. So that's what this deep excitatory loop and then the cortical inhibitory loop is about. Okay, don't have to know all these connections here. You do need to know that the Purkinje cell is always inhibitory. It's just whether you turn up the activity of the Purkinje cell or turn down the inhibitory effect of the Purkinje cell, and how it influences the deep cerebellar nuclei, which we'll talk about in a minute here. So there's divisions and lobes. We can talk about lobes of the cerebellum and divisions of the cerebellum. The lobes of the cerebellum are the anterior, posterior, floccular, nodular lobe. Here's the anterior lobe. This is the posterior lobe. Actually, no, take that back. Sorry. This whole thing is the posterior lobe. And then the floccular, nodular lobe, you can't really see in this cross-section here. this is the floccular nodular lobe right here. I've got some better pictures coming up here. So there's also vertical divisions. So we can divide the cerebellum into vertical divisions. And we do that when we're looking at the front, or usually the front of the cerebellum after it's been cut off the pons. And we're looking at the front of the cerebellum here. It's got a vermal region. That's the most medial, middle part, the vermis. This means worm-like. It looks a little worm-like, I guess. Then we have a paravermal region just lateral to that. Then we have these big lateral hemispheres. Those are the vertical divisions. We also have phylogenetic divisions that are based on like cell type and how old they think they are in the evolutionary process when they came on board. The oldest part they think is our archicerebellum, which is the same as our floccular nodular lobe, is the archicerebellum. And then the vermis and paravermal regions together, these regions together are called the paleocerebellum. Then the lateral hemispheres are figured to be the newest region, and that's more for voluntary movement and distal movement control and coordination, is the neocerebellum. That's the lateral hemispheres. These are the ones you care most about as a physical therapist, the functional divisions. The functional divisions is we can divide the cerebellum into a vestibulocerebellum, which just happens to be synonymous with the flocculonodular lobe, is where your vestibulocerebellum is. That's the part of your cerebellum that communicates between your vestibular nuclei and the neck muscles and upper back muscles to help coordinate them. Then we have a spinocerebellum, which happens to be the vermal and paravermal regions, the spinocerebellum. This makes sense. It's kind of in the middle part of the cerebellum, and it helps to coordinate your postural and girdle muscles. It provides the coordination for postural and girdle muscles. Then the lateral hemispheres are called the cerebrocerebellum. That's for distal movement and control and coordination. Okay. The functional divisions tell you who they talk to. So the vestibulocerebellum talks to the vestibular nuclei. The spinocerebellum, it goes to the spinal region and influences descending spinal pathways, okay? Especially those medial activating pathways. The cerebrocerebellum, it influences the cerebral corticospinal tract pathways coming from the cerebrum, the corticospinal tract pathways, and helps for coordination there. So here's looking at the front of this right here. That is the flocculonodular lobe. This right here I'm showing you, that's the anterior lobe from the front, which is not a great. Then all this down here, this is all posterior lobe down here. But if you look here, this picture here is looking at the top of the cerebellum. This is anterior, and this is posterior. This red is the anterior lobe, the green is the posterior lobe. Then this is looking at the front of the cerebellum. Red is the anterior lobe, you're seeing just the top of. This is all posterior lobe, and then that blue right there, that's the floccular nodular lobe. And this region right in here in the middle, this is your vermis. And your paravermal regions are right out here. Then the rest of this is your lateral hemispheres if you're looking at the vertical divisions. So kind of like we have basal ganglia nuclei and thalamus inside the cerebrum, the cerebellum has some deep nuclei, gray matter inside of it, okay? And from medial to lateral, the most medial nuclei are called the vestigial nuclei, and they send axons back to the vestibular nuclei and the reticular nuclei that influence the vestibulospinal and reticulospinal tracts to help coordinate your head and neck movements. The globus and embelliform nuclei, collectively known as the interposed nuclei, because they are interposed between the vestigial and the dentate. They're kind of sitting between them. They project to the red nucleus and the motor cortex, and they influence more some upper body function and some postural control muscles. The dentate nuclei, project to the red nucleus as well, and also influence voluntary control of the arm and limbs, but also to the premotor cortex and the motor cortex to influence cortical spinal tract pathways for voluntary movement to the whole body. So this is looking at, this is anterior, this is posterior, this is a horizontal section through the cerebellum. Our cortex is out here. That's where our Purkinje cells are, out in the cortex. These are the deep cerebellar nuclei. This is the dentate. It's a squiggly kind of C-shaped structure. Most medial, this is the fastigial. And here's our interposed nuclei right here, the globus and embelliform nuclei. They're interposed kind of between the dentate and the fastigial nucleus. This is this on cross-section here through an actual, this is kind of the dentate nucleus around here, dentate. Here's the fastigial, is these two guys here. This is kind of globus, and then this is embelliform nuclei in here. Globus and embelliform would be about there. So how do we process information in the cerebellum? Information has to come in, right? You got to get information in to process. So that's coming from our muscle spindles, joint receptors, all that kind of stuff, plus some of those internal feedback loops, the anterior and rostrospinal cerebellar tracts that are telling us about the interneuron activity in the spinal cord level. They're coming up via mossy fibers and then some climbing fibers from the inferior olivary nucleus. They enter via the peduncles. Most of them come up through the inferior cerebellar peduncle to get into the brain, into the cerebellum. A few of them come in the superior cerebellar peduncle, and a few come in. Some come from in the middle cerebellar peduncle. So they all come in from different regions, but a good proportion come from the inferior cerebellar peduncle. They synapse in the cortex. That information goes to the cortex. It's processed in the cortex via those interneurons and that activity. And then the Purkinje cell is modified. The output for the Purkinje cell is modified by that input. It's either less inhibitory or more inhibitory based on the input. The Purkinje cells then go back to the deep cerebellar nuclei and affect the output of the deep cerebellar nuclei, which then go and communicate with motor structures either in your cerebral cortex or your brainstem, your vestibular nuclei, to then help modify the next motor signal coming down or going out from your brainstem nuclei or from your cortex to tell it, turn it up, turn it down. Does that make sense? Okay. So here is looking at some of those things. So here is the mossy fibers and the climbing fibers. The mossy fibers are bringing in information from those spinocerebellar tracts of the inferior cerebellar peduncle. Here's the climbing fibers from the inferior olivary nucleus. Those are bringing in also a copy of motor output. Those come in to go to the cortex. We also have cortical pontine fibers, which communicate with these little pontine nuclei in your pons that send signals into your cerebellum via the middle cerebellar peduncle. And that's primarily how most information gets into your cerebellum. Then your Purkinje cells will, that information is processed, and your Purkinje cells then will project to these deep cerebellar nuclei. Then the deep cerebellar nuclei will go to either up to the thalamus, into the cortex, to the red nucleus, to the vestibulospinal tracts, to reticulospinal tracts to influence the next motor output or motor signal in response to whatever's happening from the input that just came into them. They're like your cerebellum is like the anti-lock brake system in your car. You know, like you go to slam on your brakes, your anti-lock brakes know that you push too hard, so it adjusts it so you can't skid. The cerebellum's kind of the same way. It upregulates or downregulates motor activity based on what it's experiencing and sensing in the outside world. I'll draw it out here, I think, before. Okay, let's do it simple here. Nothing's been simple today, I know. Let's talk about a voluntary motor. Let's talk about a voluntary motor act where I'm saying I'm going to choose to pick up that can of soda. Okay? Here we go. Let's follow it. We send a signal. Remember, though, it has to go through the basal ganglia first. So we already looped through the basal ganglia. Yep, I'm running. My battery's running low. My mind is running low. Their minds are running low. So we're good here. I hope we got another 4 minutes. You send a signal down, right? Comes down in here, brainstem, crosses over, goes to the other side. It's going to go out to your arm to do whatever activity, right? That's the cortical spinal tract. Well, during that process, you have a little collaterals that come off here. And there's some cell bodies here in your pons. This is your pons right here. You send a copy of that message to the cerebellum. You say, hey, you know, I'm going to be sending this signal down to my arm to do something. The cerebellum gets a copy of that. This fiber right here that comes off the cortical spinal tract, that's called a corticopontine fiber because it stops in the pons. And it talks to a pontine nuclei. There's little nuclei in the pons, and you'll see these when we get through cross-sections of the pons. Then an axon projects from that to the opposite side, that opposite cerebellum over here, okay? So that's your little copy of the message. This is what's going down to my muscle to tell my muscle what to do. Your hand starts to lift that can, and that can is fuller than you thought it was, or it's more slippery than you thought it was, so you need to grab it tighter, right? So now you have signals coming from sensory information that comes up, goes into the inferior cerebellar peduncle from your receptors of your joint receptors and muscle spindles that says, uh-oh, I need to increase force on the next signal coming down now, quickly. I don't even have time to think about this hardly, but so let's just do this. So these two signals are compared, and there's a mismatch. My original signal was not strong enough because I'm noticing that my muscle spindles and joint receptors are telling me I didn't create enough force, and that can is slipping out of my hand now. I better send a signal to tell the next signal coming down to those muscles to ramp up the force. So the Purkinje cell is modified. In this case, the Purkinje cell, then let's make this in green. Purkinje cell in the cortex projects to a deep cerebellar nucleus. In this case, since we're using our hand for a voluntary activity, it's out in the dentate because it's out in that lateral hemisphere. So here's the dentate nucleus here. It projects to the dentate. Then the dentate has a cell body that then crosses over, goes out through the superior cerebellar peduncle, goes up to the thalamus, because we got to talk to the thalamus before we go back to the cortex to tell the next signal I send back to the hand, that signal should be a little stronger. I need to contract that muscle a little, or maybe it was too light and I'm crushing the can. I got to downrate it. Just whatever it needs to do, it modifies it based on that communication that occurs. You're comparing your actual motor, or you're comparing your intended motor output with what actually is happening and then making modifications along the way. Does that make sense? That is for the voluntary. Okay. Yeah.
So do you notice those modifications sometimes?
It's not conscious, but you would notice them because you would be successful in the task. And you're not always successful. There's learning that occurs. The first time you do it, you might actually crush that can a little bit before the next time you do it, you might recognize something about that can that gives your, that next time I pick it up, that following time, now I've made that tweak and now I've reset my Purkinje cells in my cerebellum and reset those signals so that the next time I pick it up, I'm not going to crush it because I've learned from that previous experience. So sometimes you're not quite, you still, when you're learning a new task, even with your cerebellum doing the job, it still looks a little uncoordinated. And so, but over time, you tune the Purkinje cells so that they learn and now they're at a different set point so that you modify them so that you've got a stored program in there, okay? So you're more likely to get closer to the real movement the first time, the next time, if it's a very similar task, okay? Whew, that was a lot.